Good evening, everyone. Welcome to the AMI webinars. The Academy of Minimally Invasive Implantology was established in 2017 and spread around the world to teach the latest minimally invasive techniques for implant treatments. Tonight, I have the great honor of welcoming Dr. Zoltán Nyárády, who is a Hungarian doctor, an oral surgeon, an oral maxillofacial surgeon, and a dental surgeon specialized in implantology. He is, in an opinion, a key opinion leader for the AMI Academy and also other major dental societies. Good evening, Dr. Nyárády. Welcome to our webinar.
Hi, Harold. Thank you very much for the invitation, both for you and both for Youngsek. It's a great honor to be here in this webinar. Today, I will speak about immediate loading of IBS MagiCore implants, and I will present a case which is very near to me because it will be my mom's case, which is one of my first cases. So let's start the lecture. Let me introduce myself. As Harold told, I'm an oral maxillofacial surgeon. I work in Hungary. My biggest hobby besides dentistry is teaching. I'm teaching for AMI, IFCI. These are two implant companies. I also teach at the local university in Győr, where I live, and I hold lectures for XNF Technologies, Nobel, and I'm also a key opinion leader for the Dental High-Tech Academy. Our office is located halfway between Vienna and Budapest in Győr. This is a very lively little city where we have a small family practice since 2019. Our practice is mainly focused on prevention, and we try to have a good familiar attitude. So in my belief, dentistry is all about teamwork, and we try to have a good team. And I have my wife who really helps me with that. This is my office in 2019 when we opened, and since then it changed a lot. It gets lots of gadgets, lots of monitors, computers, devices. My wife is not so happy about it, but I like it because this way we can be on the forefront of digital dentistry. My favorite is the X-Guide machine, which I exclusively use for all implant cases to do navigated since 2022. I would say it was my 52 years birthday present. So where do I work? I also a visiting consulting surgeon in Norway and a couple of clinics, besides working in Hungary and the previously mentioned places. And yes, you can see it's good to do these places and enjoy the good mood of your colleagues. In Alta, our receptionist, Victoria, makes these funny jokes to cheer us up. And this is Victoria. She put out these small stickers, and I will have a couple of stickers during my lecture to remind her, and also the good mood she's taking to us. So how did it begin? I went to Rome, and you know, Rome is the city of love. And this was an EAO meeting in 2014 where I fell in love with the IBS techniques. I've seen David, the Korean guy on the right, and this was the last day of the Congress, and he was showing a couple of instruments, and I really fell in love with the instruments. Of course, not with him. I still have my loved family and my wife whom I'm in love with. Anyway, he was showing me a very nice small box with a lot of magic instruments. It was called Magic Kit, and I immediately bought two. This is the Magic Kit, but let's put it aside and continue how we begin to use it. I begin to use the first FC implants a little bit later. IBS was trying to convince me, but those days I was working as a consultant surgeon on other places, and I didn't have the chance to bring my own implants and my own kit. They were not in Europe those days yet. So I kept a distance, but around 2018, when I made my first private venture, I begin to use the FC implants, and after some consideration, which took also some time since 2019, I do use the MagiCore implants. In 2020, I was invited to a KLO course to Korea. It was a very nice course. I get to know a lot of good people whom we still keep in touch, and we are good friends since through AMI. But let's go back to the topic of the lecture, and let's begin it at the beginning, okay? Perry van Breunemark discovered osteointegration in 1965. It was a serendipity, it was an accident. He was looking at the microvascularization of rabbit bones, and he discovered when he was using a device, which was very expensive, made of titanium, it always broke when he wanted to remove it, while the stainless steel devices, which were looking the same, getting from the same manufacturer, didn't break. A normal researcher would have just changed to stainless steel and continue his experiment. He began to examine why the titanium device is fractured. And the end product was the Breunemark implant system. According to his original protocol, the implants must be sterile, made of high biocompatible materials such as titanium, inserted with an automatic surgical technique, and they should have had good primary stability, and they should have had a submerged healing period. And this healing period was pretty long compared to today's standards. Most of his protocols is still standing, but since then we come to a long thing. This is because the original implant had several problems. It was bone resorption around the neck of the implant, loosening the screw, and so on. So a lot of companies put a lot of effort into it. Finally, we come to the new era in 2013 when the first MagiCore implant was produced. The magic post of the implant introduces a new concept in prosthetic treatment with an enlarged field of use and durability. The magic cuff protects the junctional epithelium and adherent connective tissue. The one-body structure avoids lots of problems with two-parts implants, like screw loosening and fracture. And the magic thin thread transfers the occlusal forces to the bone gently, protecting it both during and after insertion. If you take a look at this picture, you can see that while with a normal implant, we need at least to have 1 millimeter of bone on both sides of the implant. In the case of MagiCore, because of the deep threads and the very thin threads, there's enough bone volume that this space is only 0.25 millimeter on both sides. This generally enhancing the place we can put the implants in. This new trend appeared also in the other implants. They begin to make new tissue level implants. Nobel come out with the On-One concept. Ontogir made the tissue level implant. How do we select the cuff? A lot of users are afraid of tissue level and one-piece implants due to the angulation and aesthetic problems. If one understands the concepts and make proper planning, aesthetic results easily exceeding those with two-piece implants are easily possible in long term. You have to take the gum as a reference level and then pick a cuff size according to the planned implant position. And then let's take a look what are the soft tissues next to the implant. I have to tell you that what I will show you in 2 slides only, Dr. Giacomo Fabri talks about half a day on one of his courses. I really recommend this course. It's really good. It helps you to understand why a transchangeable approach is a good thing and what advantages it has, though he shows it through a different implant system. It helped me a lot to understand it. So let's take a look at the anatomy of the gum around the teeth and the implants. On the left side, we have the tooth and the sulcus. The junctional epithelium is attached to the teeth. with hemisom desmosomes firmly. In the case of the implant, the peri-implant epithelium here resembles the junctional epithelium, but is not as a firm attachment. It can be easily penetrated by a probe down to the bone. It is much more vulnerable than around the teeth. The biological width around teeth is usually 3 millimeters. Around the implants, you need a longer barrier. If you take a look of this slide, the important thing here is this removed healing abutment from two-place implant. You see the 3 levels. The lowest 1.25 millimeter is the connection tissue, which basically seals the implant from the bone from the outside world. And this is the most important part of it. This is what we have to preserve. If we use a two-piece implant, each time we manipulate, we damage the peri-implant tissues. In the case of a transgingival implant, we don't need to do that, and we will face something else, which is called on-growth, instead of you losing the bone. You can see here implanted insertion, the crown when delivered, and a couple of months later. The implant also comes with a very nice proven simplified drilling protocol, which means you drill one hole and then you use a very low rotational speed to shape the bone for the implant. If you look at the current stand, other companies are introducing this simplified drill protocol. Nobel introduced it with the Noban, Axiom with the X3, and also Straumann with the BLX. So it seems to be the future. And then let's get a little bit why I choose this implant. I like it because it's a minimally invasive implant. Why do we want to be minimally invasive? First, we want to give less damage to our patients. We want to have less complications, both short and long terms. We want a faster procedures and especially cheaper procedures if we can avoid excessive bone augmentation materials. And this helps not only our practice, but also acceptance and compliance by our patients. But maybe there's something else which helps a little bit. This greeted me when I arrived to Alta to my operation day. The other thing I'd like to address in this lecture is immediate loading. When I begin immediate loading, I was a bit afraid of it because I was grown up on the old traditional Brönemark protocol. But then I learned it has several advantages. One of the advantages that we need to have fewer surgical interactions. We reduce the treatment time. We also reduce the loss of soft and hard tissue. And this is the most important for me as a surgeon, because patients early get teeth, they are much happier, and we have a step to final tune our final results. The final prosthesis we can try with the temporary, and we can get a lot of ideas together with the patient during a couple of months. And it's not a one-time sit in the chair delivering the denture and then the patient is surprised that maybe it's not what he wanted. So today I will speak about my mom. In the upper jaw you can see my first implants. It was placed more than 20 years ago. This mark is not any longer on the market. But she's an elderly non-smoking woman. She is becoming 81 this year, and she had fractured her tooth 3.1. That's it. You see, I was consulting my perio specialist, Esther Szentléleki, what to do. Because it's my mom and I didn't want it to be too drastic and maybe remove the teeth, but together the three of us, my mom, Esther, and me decided to remove the 4 small incisors and give her 2 implants and a bridge. We then did an intraoral scan, CBCT, planned the whole case digitally. You see different type of implants here because in this library there is not the MagiCore implant, and I made a digital plan and I performed the operation freehand. I do recommend you that those of you who has access to digital planning anyway, and now it's not that difficult because you have several possibilities to use free of charge, to use digital planning. It will have tremendous advantages. For the clinician, we will have better predictability. It will be safer for us. We will have less stress and we will have less appointments because we can plan everything in advance. For the prosthetic specialist and technician, they understand the whole situation better, avoid the difficulties, and they will have less stress. For the patient, they will understand the whole treatment better. They can make a more conscious decision if we need to go for minimally invasive surgery, we will need gamma augmentation or bone augmentation. They understand why we want to do something, and they understand our decision steps better, so we will have less problems later on. And it's easier to show them the alternatives, and also the best, they will get a faster treatment. For anesthesia, I was using Quick Sleeper 5 from Dental High Tech. I like this product very much. The advantage of intraosseous anesthesia is that it is immediate and has full effect in every patient all the time. The other advantage for me, I use this technique more than 7 years by now, is that I learned that actually numbness is a side effect of anesthesia, and I can determine the area of anesthesia, and I can also very well determine how long I want to work and do the anesthesia only for this time. And this is a marvelous thing, even with surgery. So these are intraoperative pictures. If you do hand surgery, then you use the pin guide system. So I inserted the 2 pin guides. We made a CBCT to check the angulation. The pin guides are really good when you want to do immediate implants and you have to put the implants into a sleep slope. It helps to guide your hollow drills. Then we put in the implants. To make less X-rays, we immediately put in the open tray abutments. And you see that we were good on the plan. On these 3D pictures, you can see that this is my original plan here, and this is a temporary on the cast, which my technician made. And you can see that we were not too much off from our original plan. And I think it also helped by the pin guide system that you could fine-tune the angulation. This is a check of the abutments, the impression copings, and then we let my mom home. Day later, we checked her and delivered her a temporary denture made out of a temporary bridge made out of plastic. These are the implants at stage removal. You already have a very nice healed gum. This is the temporary a year later, half a year later. These are the implants intraorally half a year later. These are the impression copings for the final restoration. When we make bridges for implants, we always splint the implants. The best is to use, in my opinion, some kind of wire and use acrylic. It's a cheap and fast way without any torsion, without any artifacts, and you can be very, very exact with it. The impression, the technician made a cast, and then over the cast, he immediately put the porcelain. And for this, we use the burnout core cylinders. Here is the position I would like to mention, that despite the fact that this is a one-piece implant with proper planning, you can stick to screw retained restorations. since I used the MagiCore implants during this time, since 2019, during the 6 years, it was only 2 implants in our practice, with more than 1,000 MagiCore implants inserted, which were not screw retained but were glued. So if you focus on that, you can really achieve, with proper planning, a good angulation, and you can make a screw retained denture, which is the industry norm nowadays. This is the bridge at final delivery, post delivery X-ray, and this is the smile of my mom. This is at 1 year, 2 years postoperatively, 3 years postoperatively, and this is at the last checkup when we removed, cleaned it, and this is how we put it back. And thank you very much for your attention.